Hi everyone, we're going to be presenting our client care case. It's going to be presented by Sumaya, Sajila, May, Ellen, including myself. Starting off with the client profile, the client was female, 57 years, with Middle Eastern background and no dental insurance. At first appointment, blood pressure was taken and it was 144/77, and then after 5 minutes it was retaken. It came down to 118/81, and the pulse rate was 80 beats per minute. The client presented with a chief complaint of soreness upon palpation near tooth 1-3 and 1-4. So I would like to ask you guys to think about possible diagnosis. And if you thought about a fistula, that's right. Upon completing intraoral exam, a fistula was noted between teeth 1-3 and 1-4. So let's think about what could be the next steps be. The condition was discussed with the dentist, and the student also explained about the oral condition, about what is fistula, what causes it, and how to treat it. And a P was taken, and also possible treatment options were also discussed with the client, such as extraction, root canal, and implant. And also the client also had a second chief concern regarding mobility on a man anterior. The student asked probing questions regarding how long it's been bothering her, has you noticed it recently, and when was the last time she completed the comprehensive assessment.
So the client's last medical exam was on the 17th of February 2022, so 3 weeks prior to their first appointment. The client reported presenting with slightly high cholesterol levels, and sugar levels are being monitored by the physician with an A1C level of 5. However, they're not taking any medications directed to those high levels. Instead, they're focusing on lifestyle modifications and monitoring for diagnosis instead, as recommended by their physician. The client is taking, however, over-the-counter vitamin D, which has no direct effect to their oral health. As for their dental history, the client last seen the dentist 6 months prior to their first appointment at Algonquin, and their last cleaning was in the year of 2022. So what kind of probing questions can you ask the client to discover the reasoning for their infrequent cleanings? So this student used probing questions and discovered that the client reported only seeing the dentist when needed, so only when they felt pain or had any concerns, and their last dental visit was due to an infection on tooth 3-6. Some problems to be examined immediately. So their chief complaint, as mentioned by Fatima, was teeth mobility on the man anteriors and soreness upon palpation near tooth 1-3 and 1-4. The client indicated the following are or have been present: gums bleeding while brushing, teeth sensitivity to cold, sore spots in their mouth as indicated in their chief complaints, clenching and grinding, and bad breath. The client also reported having lost fillings, teeth extractions done, loose teeth on their man teeth, and the oral aids the client uses are dental floss and toothpicks.
Okay, moving on to the assessment, extraoral exam to be within the normal limits. For the intraoral exam, findings has been all noted, and we see that the unique finding in that exam is the 1-by-1 lesion between the 1-3 and 1-4, which is associated with pain and discomfort. So it's due to the existence of a fistula. For plaque and calculus assessment, we see the scores noted here. There are mainly 1, and the calculus statements has been also implemented. So they are between light to moderate and some localized heavy in max and mand specific areas. Moving on to the periodontal exam, we see a lot involved. We see mostly some mobilities in several teeth with grade 2 and grade 1. And we see probing depths that are deep, such as tooth 2-6 has 8 pocket depth, and tooth 1-7-4-7 has a pocket depth of 7. And then we see a unique finding in tooth 1-3 with a 9mm pocket depth on the lingual side of the distal. Moving on to the client habits and knowledge, it has been also collected by the student dental hygiene, and a unique finding in that, it was a generalized brown staining from the chlorhexidine. And based on the prescription of the dentist, 4 bite units has been taken, and I would like to take the time to ask you guys to look at these pictures and identify the types of bone loss that has occurred. So horizontal and vertical bone loss, they both have been occurred based on these pictures. We see generalized moderate horizontal bone loss and a vertical bone loss on tooth 2, 5, 3, 7, 4, 6, and 1, 6, all on the mesial surfaces. And we see a composite on tooth 4-7 and an amalgam on tooth 4-6 and 3-7. Moving on to the last picture of the rad, it's a PA of tooth number 1-3, and I would like to take the time also to ask you why this has been prescribed. And if you guys remember, it's due to the lesion that has been found in the intraoral exam and also the client presenting with a chief complaint on that area. So you can take the time to look at this picture and see the unique finding in there. And this is what we see. We see an infection around the root area over there of the tooth 1-3. So based on the assessment that has been noted and documented, the diagnosis, so the periodontal statement that has been noted is basically stage 3, grade B, and that's due to the bone loss, to the probing depth, and other assessment that has been collected. And we believe that the client fall within the DD3 level based on the assessment findings. So I'll leave Ellen with the care plan.
Okay, so based on the assessments presented by Sumaya, the student created 4 human needs. They created goals for this needs that were presented to the client and the interventions that the student was going to perform in the treatment sequence. So the interventions included OSC, regarding brushing and flossing, regarding the use of chlorhexidine, debridement, and discussing with the client about the need for regular dental visits, and also referral to the DDS regarding root canal therapy for tooth 1-3. So the student implemented the treatment or the care plan in 4 treatment appointments. This included gross debridement of the quads to take off as much calculus as possible. The debridement was done using ultrasonic and hand instruments. The ultrasonic was imperative in maintaining the client comfort with the amount of calculus present, and to regate the gingiva and increase healing and reduce the number of appointments needed to complete the client's care. The use of hand instruments was used for fine debridement. Gross debridement using the ultrasonic of each quad was done to remove as much calculus and stain as possible. For AGP room purposes, the clinicians advised the student that it would be best to take advantage of using the Cavitron and hand debriding when in non-AGP rooms. So in future slides, we're going to discuss why gross debridement is not an ideal approach. So the barriers we faced or the student faced in implementing the care plan, one was access to the AGP rooms. Another was because the student had to focus on gross debriding, going over brushing and flossing technique was implemented at later appointments. There was lack of understanding by the client for the need for root canal therapy, and the client was not able to successfully understand or explain their needs to the clients due to language barrier. The successes faced by the student included effective use of time management and using the AGP rooms to reduce the amount of treatment appointments. Although the client did not understand the need for root canal therapy, the client still sought consultation at a private dental office, and the client was able to stop using chlorhexidine as a regular mouthwash and only used it as prescribed by the dentist. So the treatment sequence was evaluated at each appointment. OSC was evaluated at every continuing care appointment. Each quadrant was evaluated after debriding to completion. The goals set by the student and the client were evaluated during the current care cycle, and a 4-week reevaluation has not yet been completed for this client. The recare interval set for this client is 4 months. And in evaluating the goals, the client stopped using chlorhexidine and only used it as prescribed by the DDS after she was educated by the client. And the client sought consultation for treatment of tooth 1-3, but she hasn't decided if she would follow through with the recommended treatment plan.
So regarding the reflection that we've done on this case, the student had the opportunity to learn how to ask probing questions in regards to where the stain came from. So really asking if it was from smoking, your diet, or any medications prescribed. Also learning about question asking during health status, such as why you're being evaluated for diabetes, your cholesterol, and really getting in-depth answers so you're providing safe care for your dental treatment. And then going in depth into the client's chief concern so you understand the client's needs and where you want to start treatment, who to recommend, where to refer them. Explaining the need for the root canal even when the pain is not present, as Ellen mentioned that the client did seek the referral. However, she did not want to continue with treatment because there was no pain associated. So we'll talk a bit more about that and how to proceed when a client presents with that kind of approach. Also adding on managing client comfort throughout debridement and air polishing. When a client has heavy to moderate calculus, it can be uncomfortable, especially when you have pocketing and mobility, ensuring you're keeping your fulcrum as a provider, and you're making sure that you're doing safe treatment for the client, you're asking them, you're talking through them to make sure that they're comfortable as well in attending their needs. And due to the slight language barrier, you want to make sure that you have effective communication so that there's understanding between you and your client, there's proper rapport, and that there's nothing that's being assumed or misunderstood by either the client or the provider. So overall, even though the client was a DD3 and not a DD4, there was still many factors to consider when managing the case, such as the tenacious staining of the chlorhexidine, the tooth mobility, the deep pocketing, the language barrier, the lack of oral hygiene, and the extensive dental history present. So going in more details about new knowledge gain, this can be talked about in regards to the effects of chlorhexidine on the mouth. So we would ask the class about any other possible side effects other than staining for chlorhexidine. What would you guys assume? Because the most common go-to answer is just tooth staining, but there is a lot more to that according to lexicon and the CDO fact sheets. So it does increase calculus formation. So as we know that calculus is a result of a precipitation of calcium phosphates and salt that is in the plaque, and it leads to that hard mineralized material that attaches to your tooth. So what can happen is after the intake of chlorhexidine, it increases those salts in your mouth and increases that calculus formation. Adding on, it could be informed your client about the risk, the benefits, and everything when you are getting prescribed chlorhexidine or prescribing medication like that. So the client knows about all the side effects and how to really intake that medication. And it's important to inform your client when they're still taking it for that reason that they should disrupt the biofilm prior to the start of taking that chlorhexidine to reduce the side effects associated to the calculus formation. Also, the chlorhexidine has effects on altered taste perception, so things can taste a bit different. Not only does it stain teeth, but it also stains your oral surfaces, such as your mucosa, your teeth, your dorsum surface of your tongue, which is the top, and it can cause oral and tongue irritation. Lastly, the staining can be visible as soon as 1 week after the start of therapy. So that is something that your client should be aware of. Adding on, as we know that the client had the fillings present in her mouth, staining from chlorhexidine can increase accumulation on unremoved plaque and teeth fillings that have the rough surfaces. So that caused her oral health hygiene to present a lot worse as well. And if not removed clinically, it can present with more adverse effects and possible more risks of disease and so on. So in terms of how we would manage this case differently, we would ask more probing questions regarding how often she would like to go to her cleaning regularly prior to COVID, as she hadn't gone after COVID had started. And more questions about her regular dental visits, such as her assessments, what she usually gets done, and so on. Also, in regards to the 1-3 treatment, it should have been included in the informed consent regards to recommending dentures so that she can decide exactly what is the best treatment option she prefers. In regards to educating the client in regards to her root canal, because she was a bit incompliant about understanding the need to seek it, even though she has no symptoms of pain, showing her through visual aids, pamphlets, videos, and pictures instead of just verbally explaining it can really help the client understand more about the need to seek it to prevent further infection, worsening of pain, chronic and acute infection, and so on. And lastly, the client didn't have adequate knowledge about the decay process or gingival condition. So this should have been added to the care plan as it was not mentioned, or the client was not educated on that. More changes that could have been made into this case was adding and making changes to your care plan and your treatment plan is really important when you see goals not being met. So as Ellen mentioned, the goals that weren't met in regards to seeking care for the root canal, that should have been the goals should have been changed in the care plan to meet the client's needs and their timeline to make it more achievable for them. It was also forgotten to make an intervention on mobility and make the right referral for mobility. It was not also mentioned in the progress notes any recommendations to the client that should be done to help maintain their mobility and precautions for mobility at their home care. Adding on for their blood pressure, as Fatima mentioned, that their first reading was a bit high, and after 5 minutes, even though it was normal, because that first reading was high, blood pressure should still be taken at every appointment to make sure it's still managed and there's no referral needed. Um, and as Ellen mentioned, there was gross debridement done, and this is not an ideal approach to care. And that is because it is an outdated approach, and it is not the best practice. So the correct approach would be to debride to completion and aiming to do quadrant or sextant debridement. This is because the gross debridement leaves behind residual calculus, which can lead to inadequate healing of the gum tissue. So what happens when the hygienist goes back to re-entry for completion at the site, it can be very uncomfortable for the client and cause tissue trauma. And it could also lead to further infection and periodontal abscesses. Now I will pass it on to Fatima.
Well, the case was client-centered from different perspectives, such as such as the student has used public health recommendations and also explored different resources, as well as external referral form were used for RCT, and also the student provided different treatment options for 1-3 affected tooth, such as extraction, implant with crown, or RCT with crown, as well as the clinician and the dentist were both involved in educating and providing this necessary information for getting right treatment for 1-3, such as RCT. And this was the end of our presentation. Thank you so much for listening. Thank you.